Cancer. Welcome to the Blood Cancer Awareness Workshop. We wanted to let you guys know that this presentation will be recorded in case you guys miss anything, or for those who are unable to attend today, this will also be posted on YouTube. I wanted to introduce Sally Glover from South Sound Care Foundation. She's going to be talking a little bit about South Sound Care Foundation, as well as introducing one of our sponsors, Oncopeptides.
Hello, everyone. I am Sally Glover, and I have the honor of working with Dr. Frank Senecal at the foundation that he founded about 10 years ago to provide more cancer research options in the South Sound community that are typically underfunded, and providing a little more hope for people that are running out of options. So we are completely funded by philanthropy, including several of the pharma companies that are with us tonight. And our big fundraiser is this weekend, Beer and Bites. Unfortunately, it's virtual this year, so we will be on a live stream and have bidding online as well, and close our live items live on Saturday night. It starts at 6. So if you would like to tune in and check it out, the website is rushtobeerandbites.com. Hopefully next year we'll be live and you can join us live. But we are very fortunate to have had a partnership with Oncopeptides this year, and just love the community support and advocacy that Elaine McNeely at Oncopeptides has brought forward with us, and both at granting our program, sponsoring this program and our Beer and Bites program as well. So just want to thank all of you for being here, and the cancer support community for the work going into providing some great information during Blood Cancer Awareness Month. So thank you for having us. And Eunice, I'll turn it back over to you.
Hi, welcome everybody. My name is Eunice. I am a patient navigator here at Northwest Medical Specialties, and I am also the Cancer Support Community Program Coordinator. So I welcome you. I would like to give a big thank you to 4 of our pharmaceutical reps that are exhibiting here today. We've got Janssen Oncology, Pharmacyclics, Acceleron, and Seagen. Thank you so much for sponsoring our events. This all comes back to you guys. So thank you once again, and I'm going to go ahead and pass it to Catherine.
Hi guys, my name is Catherine, and I'm a research assistant at Northwest Medical Specialties. I'm also a committee member of CSC. I wanted to introduce Cancer Support Community and who we are. Cancer Support Community is the largest professionally led nonprofit in the world, providing free cancer support to everyone in the community who has been touched by cancer. Through our partnership at Northwest Medical Specialties, we are able to bring free programming like these educational workshops, healthy lifestyle classes, social activities, support groups, and other resources and support. We do this so no one has to face cancer alone. And I'm also going to be introducing and passing you over to my coworker, Abra, who's going to be talking about Dr. Namburi's bio. But before that, we do also have some housekeeping that we wanted to let everybody know about. We have everyone muted, and we ask that everyone keep themselves muted for the duration of the presentation. We also have allotted time at the end of our presentation to answer any questions that you guys might have. If you think of something during the presentation, you can also put it into our chat box down at the bottom. And we recommend, for the best viewing option, please use the speaker view. And as I said earlier, the slides will be made available after our presentation. And I'm going to switch it over to my coworker, Abra, to introduce Dr. Namburi.
Great, thanks, Catherine. Well, it is my pleasure and honor to introduce Dr. Swathi Namburi. Dr. Nimbury is a hematologist and oncologist with a special interest in blood cancer and breast cancer. She's a board member of the South Sound Care Foundation, what we heard about tonight, a foundation that strives to bring groundbreaking clinical trials and cancer research to the South Sound region. And we have their website here, and we can add all these to the chat as well. She also serves as a Washington State Medical Oncology Society board member and is an active member of the Washington State Medical Association and Quality Cancer Care Alliance. which is a national organization that is known for bringing high quality care to patients across the United States. Dr. Nimbury became a provider because as a physician specializing in hematology and oncology, her daily interactions are filled with so many triumphs and heartbreaks. She is honored to be a part of the most important journey in most people's lives. She enjoys spending time with her family, exploring the natural beauty of Washington, hiking, and reading great books. Now I'm going to pass it to Hannah, who's going to introduce our next speaker.
Hi, everybody. My name is Hannah. I'm the Patient Access Coordinator at Northwest Medical Specialties and also a member of the Cancer Support Community. Dr. Tony Blau founded All for Cure after 27 years as a professor of medicine, hematology, and physician scientist at the University of Washington. His research has spanned hematopoiesis, gene therapy, stem cell biology, genomics, and cancer, consistently focusing on bringing the very latest research advances to patients with heretofore incurable diseases. At University of Washington, he founded the Center for Cancer Innovation, which brings together a distributed network of investigators to help patients with advanced cancer. Dr. Blau co-founded the UW Institute for Stem Cell and Regenerative Medicine and chaired the Molecular and Cellular Hematology Study section for the National Institutes of Health. He has authored more than 85 scientific publications. Diagnosed himself with myeloma in April 2015, Dr. Blau infuses All for Cure with an incredible sense of urgency to improve the prospects for cancer patients now and in the future. And I will hand it over to Caitlin.
Thank you, Hannah. Hi, I'm Caitlin Graves, and I'm a social worker at Northwest Medical Specialties. I'm also program director for Cancer Support Community, and I have the privilege of introducing Dr. Frank Senecal tonight. So Dr. Frank Senecal is a hematologist and oncologist with a clinical focus in breast cancer and general oncology. He is currently the Director of Oncology for the Franciscan Healthcare System. He was formerly the Chief of Staff at St. Joseph's and St. Francis Hospitals. He was also the Medical Director at Hospice of Tacoma and Chairman of the Department of Medicine at St. Francis Hospital. He's the founder of South Sound Care Foundation, a foundation that strives to bring groundbreaking clinical trials and cancer research to the South Sound region and to provide residents with cancer treatment options that are unavailable. To learn more, we've shared this website already in the chat, but you can go there to learn more about South Sound Care Foundation. Dr. Senecal enjoys being with his family and 6 grandchildren. He enjoys hiking, fishing, and climbing the great outdoors. Dr. Senecal became a provider in hematology and oncology so that he might be able to use the best science with compassionate care for those who need him. So without further ado, I'm going to pass it to Dr. Namburi, and she's going to start us off tonight.
Great. Hi, good evening, everybody. I'm very excited to be here with you today. And I get the privilege to talk to you about acute myeloid leukemia. So I am going to share my screen. Hopefully this works out. There we go. Yes. Can everybody see that okay? Great. You know, some of these slides were reviewed by, or actually most of them were made up by the Cancer Support Community and were reviewed by another physician as well last year. And then I've modified a couple of them so that to have a better kind of personal touch to it. So this workshop was developed by the Cancer Support Community, and then we developed the content independently and then had outside medical and psychosocial experts review it. This program has been sponsored by Stellis, Daiichi Sankyo, and Jazz Pharmaceuticals. And you know, our local community organization is putting together this event. I don't have any financial relationships or affiliations to disclose. So we'll kind of, go over what is AML, some aspects of treatment planning, making treatment decisions, communication with healthcare teams locally and for second opinions, as well as kind of some common aspects of managing side effects and living with AML. So, everything kind of happens very quickly, unfortunately, for patients that are diagnosed with this acute leukemia. And it's important to really sort of help others help you and to build a support team, because everybody does want to help, whether it's your friends, your family, your physician, the nurses that are taking care of you. It's a scary journey to do all by yourself. We have social workers, patient navigators, a lot of people who are familiar with this whole new world that you're thrust into without much preparation or warning. So speaking more specifically about AML, it is the second most common type of leukemia in adults. There are about 21,000 new cases per year of this disease, and any person can get AML, but it is a lot more common in older patients. But even children and adolescents can get AML. It can result from previous exposure to chemotherapy, or a previous blood cancer that's like a pre-AML sort of change that happens over the years, where your blood counts drop and your bone marrow doesn't work very well, called MDS, and then turn into AML. But really, most of the time, it's really from just bad luck. It just happens, and then we all have to help deal with it, and then live with it. So what is AML? So the A stands for acute, and later today you'll hear from Dr. Senecal about the more chronic blood cancers. An acute leukemia happens very quickly over the course of several weeks to a few months, and can grow even from day to day to become very aggressive. So that's where the acute comes from, that typically people need to be treated quite quickly, and that it's they don't feel sick for months and then present to care. They usually feel sick for maybe a few weeks tops, and before they are sick enough to need medical attention. Myeloid refers to what cells become cancerous, and I'll kind of show you an example of that in the next slide. And leukemia stands for leuc, which stands for a white blood cell. So cancer in blood cells that are kind of floating around in your blood is what leukemia is. So this is an obligatory slide that all of us in the medical field encounter at some point, and I kind of made my own little modifications to it. So in usually your large bones, the low pelvic bones, the femur, and the lower part of your spine when you're an adult, we're all familiar with that little spongy liquidy tissue in the middle called the bone marrow. And this is where all your parent blood cells live. And there's different lineages. This is called sort of, as these cells sort of mature, they turn into the blood cells that we're most familiar with. Most people are sort of familiar with maybe their platelets. These are the ones that help form blood clots. The erythrocytes, these are the red cells that carry oxygen to the rest of your blood. And then the rest are all different kinds of white blood cells. So there's many different kinds of white blood cells, and each of them have a different role to play in your immune system. Myeloid leukemia means that this cell tries to turn into this cell, tries to turn into these cells, but something goes wrong and it goes a little crazy and decides to multiply and invade your bone marrow, and then it goes into your bloodstream. When people have AML, it's this progenitor cell that becomes cancerous. When people have ALL, which you may have also heard about, is the other acute leukemia, which we won't really go into today, it's the lymphoid progenitor cells that become cancerous. And the ALL is more common in children and younger folks, but older patients also get it, but it's a little bit more rare. And AML is the opposite, more common in older patients and a lot less common in younger patients. So, what happens? These cells, some sort of signal goes awry. These cells decide to multiply on their own and take over a large portion of your bone marrow. As a result, people have what are referred to as constitutional symptoms, almost like a flu-like illness. They may have unexpected weight loss, fevers, they're sweating more, they start noticing that they're bleeding more, maybe in their gums or in their skin. They may notice some bruising. Then they're just very tired, just not like feeling like themselves. And the most common problems tend to be, low production of all these cells that can no longer be properly made because their parent progenitor cell is not working properly. So they don't have enough platelets, they don't have enough red blood cells, and they may have too many white blood cells, but they're really these abnormal white blood cells that don't really work. The good white blood cells, neutrophils, the mature kinds that are down here, are in low quantity. So people can get very fatigued if they don't have enough blood. They may start bleeding if they don't have enough platelets. And they often may present with infections because it's really your whole immune system, your army that fights against infections that has developed cancer. If your doctor suspects AML, there'll be a lot more tests that will be done, including just regular blood tests, a bone marrow biopsy. So that's an attempt to actually get to the source and get some of that bone marrow tissue to be able to do all the extra tests that we do nowadays to figure out what kind of treatment makes sense for patients. And that includes chromosome tests. Flow cytometry refers to, and your blood is sort of goes through a machine one by one, and we try to pick out what are the abnormal cells in that, and all kinds of different genetic and DNA tests that are done nowadays for AML treatment. AML has several subtypes. Back in the day, before they had all these modern genetic tests, the subtypes were based on how they looked under a microscope. Something very simple like that back when Dr. Senecal first started his practice. But nowadays we have all kinds of genetic tests, and AML is more defined by actual molecular and chromosomal DNA changes that really define its biology and how people do long-term. Especially with a disease that's a bit more rare and aggressive, such as AML, it's important to consider second opinions and consider where you want to be treated. You also have to keep in mind, where people can give you the support that you need in order to successfully undergo treatment. From down here, we often will send for second opinions or for clinical trials up at University of Washington, Seattle Cancer Care Alliance, or Swedish. And then sometimes we have a trial ourselves, such as one that we have with University of Washington, where we try to observe patients, how they're doing under a certain protocol that we use to treat AML. So it's always important to be upfront and have a comprehensive discussion with your doctor about all of your options for treatment. Choosing your healthcare team, it's very important, and it's important that you developed, both trust and that you feel that you're being listened to and respected during your treatment, especially because AML is certainly one of the most serious diagnoses really any person can have, and it's important to let us always know, what other medicines you're taking. What are your priorities for treatment? What are your goals from your treatment? And to always be updating us about your side effects and any symptoms you may experience during your treatment, so we can do our best job helping to take care of you. And really, every person is different. Every cancer is different in every individual. And it's important to let us know what you specifically need or want. Some patients want less intensive treatment, even if they're eligible for more intensive treatment. Some people are very interested in clinical trials. And it's always important to find a doctor that's comfortable taking care of AML, because not all physicians that are hematology oncology doctors may be comfortable with it. So it's important to think about these things such as costs, finances, clinical trials, which hospital will you be admitted to, how long will you be there, what other support services are available, because it truly is a life-changing diagnosis. Now we'll go a little bit into how AML is typically treated. And this is actually changing quite a bit over the past few years. I will say there's probably been more progress in the last 3 to 5 years in AML treatment compared to the 35 years prior to that. And really, it's not even comparable. They had maybe 3 treatment options for 30 years, really only 1 or 2 for the first 20 of those years. And now there's all sorts of treatment for first line, second line, and in combination with transplants, which we'll sort of go into. So, due to the acute nature of this disease, treatment may start pretty quickly. Sometimes people present to the hospital and they're in a crisis mode, and we don't have much of a choice but to just do whatever we can to save their life. And we sort of are pushed into starting a treatment. Oftentimes nowadays, we do wait if the patient is stable enough. We try to stabilize them, and we wait for more testing to come back so we can help steer towards the most useful regimen for them. That's going to be the best case for their treatment. So any kind of what's considered fit younger adult, essentially somebody over 60 or somebody between 60 to 70 who's very medically fit, is typically treated with what's called induction treatment. So we're trying to induce a remission. And then that usually involves heavy treatment in the hospital. And then that's followed by some sort of consolidation treatment, which is to consolidate your response to the treatment. And that may include something like a bone marrow transplant, or it may include chemotherapy in combination with other medications. Palliative treatment is sort of given continuously to attain and maintain a remission, but thus far, we cannot really cure the AML. It sort of comes back. The only curative treatment that we currently know about is this intensive treatment that requires very aggressive chemotherapy. And a lot of things play a role as far as which kind of treatment is offered. Depends on the age of the patient, their subtype of AML, other medical conditions, whether they may have a donor that's suitable for transplant, as well as, personal preferences and how they feel through every phase of their treatment must be taken into account as you're planning the next phase. So a lot of the success for AML treatment depends quite heavily on how that first treatment goes, which is why it's important to really carefully think out and plan that first line treatment. If patients get into a complete remission within their first, month, 4 to 6 weeks of treatment, then they have a much better chance to survive longer and potentially have a cure from AML. The different types of treatments that are given include chemotherapy. Targeted therapy are either IV or oral medications that sort of target a specific weakness that the leukemia cell has that we detect through genetic testing. And we sort of give an agent or medicine that will use that weakness to get rid of the leukemia cells. Stem cell bone marrow transplant is often used not upfront, but once usually patients are in remission. And then we should always be thinking about options for clinical trials. And this is the way we really test new combinations. And often in AML, clinical trials are really considered the most important part of treatment considerations, just because there are a lot of amazing advances and amazing new medications available out there right now that are, going through trials and probably will be FDA approved in the future. So the standard treatment when we're trying to cure a patient usually involves sort of this induction, consolidation, and some sort of a maintenance therapy to prevent a relapse. Instead of standard treatment, sometimes low-dose treatment may be offered if there's other health conditions, or the patients do not qualify or want to receive intensive therapy, or they have something in their genetics where we kind of can predict that this very aggressive chemotherapy just won't work, or there's a low chance of it working, maybe 10 to 15% chance of it working. Interestingly, AML treatment has sort of swerved in many different directions, I will say, in the last 3 years. Sometimes even patients that get low dose therapy, if they go into a good remission, may be eligible for a low dose kind of transplant, which was not something that was done in the past, but they're doing more and more of nowadays. And that's because, if, for example, a patient has something called a P53 mutation and they have AML, their chances of really having a long-term remission or cure, or even a good remission from very aggressive chemotherapy that takes place over the course of several weeks in the hospital are so low. And we have these newer treatments where the chances of remission are higher. And so they may even go on low dose therapy initially and then still move on and have a stem cell transplant with the hope for long-term remission and cure. So with the standard treatment, people get chemo and then they're in the hospital for several weeks. They may get infections. They may need another round of treatment if they don't go into remission. And this is some of the most difficult experiences people can have with chemotherapy. Most patients get what's referred to as a 7+3 combination of 2 chemotherapy drugs. There's some variations to this that are sometimes used. And then we sometimes add other medicines to it depending on certain characteristics of the patient and their particular AML. So more targeted agents that are added to this chemotherapy. And then for other subtypes, we use sort of other options for chemotherapy depending on, again, the subtype. Once the AML is in remission, further treatments are needed to destroy any remaining AML cells that cannot be detected. And that's because we know that if patients do not get further treatment, their chances for recurrence are almost certain. At least a month or 2, if not several months of further treatment are typically required. And a lot of this is often given at the hospital when people get more intensive treatments. Now, the low dose or palliative treatments are kind of the biggest updates, I would say, over the past 3 years. And they involve low levels of chemotherapy, low doses of less intensive chemotherapy, such as with these drugs called azacitidine or decitabine. And they're combined with a pill called venetoclax. And a lot of my patients, including some that are on this meeting today, have been treated with this particular regimen. Another option is to use a different kind of chemo with venetoclax. This has really revolutionized how well we can treat patients that are older or medically unfit for intensive treatment and still help get them into remission. As a single agent, these drugs, azacitidine and decitabine, were used for a long time, for many years in the past 2 decades or so. But what would happen is their chances for remission were not that high, maybe 20%. But with the addition of the venetoclax, it could be as high as 50 to 60% chance of remission. So it's really a major breakthrough to have this combination. And there are all sorts of other new targeted therapies that have come out. When we do, for example, the intensive treatment, sometimes we add this medicine called midostaurin for patients that have something called a FLT3 mutation. For other patients that have something called an IDH mutation, there's 2 different types of IDH mutations, and there's 2 different drugs that target that. This happens about 5 to 10% of the time in AML. For patients whose AML cells express this marker called CD33 on their cell surface, we use something called Mylotarg. And anyways, there's all kinds of sort of targeted agents coming out there, and they have very specific approvals for when they can be used outside of a clinical trial setting. So either with their treatment, or if they relapse, or down the road. But just still, lots of exciting sort of updates from that end. Now, the stem cell transplant often raises a lot of eyebrows, and people have a lot of feelings and questions about it. And I'll sort of touch on it because it's probably the most important part of our treatment. But what's important to keep in mind is what we do for AML is usually an allogeneic stem cell transplant. So you get somebody else's bone marrow. When you get into the other talks with Dr. Blau and Dr. Senecal, you'll hear about what are referred to as autologous transplants, when it's really your own stem cells that are saved ahead of time so that you can get high dose chemotherapy. In this case, the point of the stem cell transplant is really twofold. One is you do get additional chemotherapy and radiation beforehand, which may get rid of some residual leukemia cells that are still there. But the true purpose is to replace your bone marrow with somebody else's bone marrow, parent stem cells, and for those cells to also kind of help get rid of any remaining bone leukemia cells that may still be in your body. And those parent stem cells can come from other adult bone marrows, and sometimes in certain institutions they may even get them from an umbilical cord blood from a newborn. And then there's a matching process that's very different from what you are usually familiar with, which is probably like the A, are you an A or a B, or what kind of a blood type are you? There's a whole different system called HLA matching that is used to find a suitable match. And it really only works when patients are in remission. So it's usually used, at a later stage, not for the upfront treatment of AML. So clinical trials are studies done by doctors and clinics to be able to test new drugs or treatments for AML. And really more recently, it's we have all these wonderful drugs. What is the best combination to really get patients into a long-term remission? And that's the question that a lot of the modern clinical trials for AML are trying to address, along with introducing new molecules and new medicines to the field. And clinical trials are available for all phases of treatment, newly diagnosed patients who don't get a good response, relapsed patients, maybe a trial for their actual transplant, a new way of doing the transplant, maybe a trial for medicine to go on after transplant to prevent a recurrence. So many settings. And if you're interested, it's important to really kind of ask questions about it, about the study. Usually the research nurses are very popular with the patients, and they go over a lot of details about the trial, and the doctors are always available to answer all these questions about how, what are the treatments? How will it affect my life? Am I getting the standard of care? Am I getting an addition to? Am I going to be randomized and not get the new treatment? What's really going on? So it's important to fully understand what you're getting into if you're going to enroll in a clinical trial. And then, a lot of things with AML treatment have to do with getting ready for the longer stays in the hospital, especially if you're getting the more intensive treatment. What I like to tell people is it's as much a mental game as it is a physical game. It's extremely difficult, unbearably difficult to be in the hospital for weeks on end. And now with COVID, it's even harder than ever because there's so much limitation in how much support others can provide in person. And so it's important to be as plugged in as possible, get your iPads and iPhones and whatever smartphones and computers all set to go, and to really figure out new ways to have your family and friends support you during your treatment, including things like taking care of your home when you're away and your pets and your children and all kinds of things like that. But people are ready and willing to help, and it's really a difficult journey without all that help. I really think about it as a mental and physical challenge, nutritionally, psychologically, physically. You may have discomfort, pain, the whole thing. And the same kind of applies for the transplant. Usually patients require very intensive hospital monitoring and treatment, or even a long hospital stay associated with their stem cell transplant. So it's important to think about it early and use all the resources possible. So I think some of this is just sort of more side effects and tips. I'm not sure how we're doing on time, but it's always important to think about also palliative options and palliative care. Palliative care does not mean that you're no longer under treatment or that your doctor is no longer treating you. It just means actually trying to think of other ways to reduce the pain and suffering that comes from treating such aggressive diseases. And that, you know, and the palliative care team's job, along with your doctor's job, is to sort of make all of this as tolerable as possible so that you can have good outcomes, but we can try to reduce the pain, stress, and anxiety that comes with these treatments. I'm just gonna kind of, and then we always try to do a survivorship visit, and all clinics should have some sort of a survivorship program for those that do become long-term survivors, because there's a lot of long-term late effects that may show up, and may show up months to years after you're done. And it doesn't mean that, you know, you're sick necessarily, but it's a lot of life that has to happen afterwards. But now you have sort of a new body, and you've been through all these rough experiences, and there'll be a lot of changes that your doctor and your healthcare team will help get you through. But it's important to seek support from other sources as well, support groups, cancer communities such as this, etc. All right, I think I will kind of end with that. I feel like I've talked for a long time. Does anybody, I think we can probably open up for some questions, and I'm not sure how the hosts will kind of do that, but that was a lot of information to cover.
Hi, I didn't receive any questions in the chat, but if anyone has any questions, you can just unmute yourself and talk directly to Dr. Namburi, or you can send me the question in a direct message if you don't feel comfortable doing so. We'll just give it another minute or so.
Great, yeah. So, yeah, you know, AML was my research topic when I was a fellow doing my fellowship. So I spent a lot of time trying to grow the AML cells in the lab, and looking at them under a microscope and doing various experiments on it. So I'm happy to answer all sorts of questions about AML. So feel free to throw me any ringers. Or I guess about transplant. I'll let Dr. Blau talk more about probably autologous transplants, but I'm happy to answer any questions about allogeneic transplants as well, because that's often an interesting topic.
Okay, well, I don't have anything in the chat, but feel free. We'll have another chance at the end of the presentation.
Could I ask,
anybody has
Namburi, I
questions,
have a
please
question for you.
ask.
Oh, yeah, so somebody else does. There you go.
Dr. Namburi, I have a question for you. Is there one particular kind of cancer that goes into AML more than others?
You're talking about the pre-existing conditions that may lead to AML.
That's correct.
So, yes. So a lot of the patients that we treat that have secondary AML comes in two forms. The more common probably still is patients that have something called myelodysplastic syndrome, or MDS, and that can evolve into an AML in older adults. So MDS is sort of like pre-AML in a lot of cases. It's still a blood cancer, but it's more of a chronic blood cancer where your bone marrow has trouble making all those mature cells. So you may have anemia, low platelets, or low white blood cell count, or a combination of the three, but you still make enough blood to kind of live a normal life and not have it really bother you, or you may get to the point where you need treatment to improve your blood counts. But sometimes the MDS can sort of take off, and the bad cancer cells can grow very quickly, and then you develop the full leukemia. The second is probably the most common setting, tends to be patients that receive chemotherapy for other cancers, particularly breast cancer, because that is the most common cancer for which we give chemotherapy as oncologists. So patients may get chemotherapy to cure a different cancer, and then a few years down the road, and depending on what drug is causing, the problem, it could be 3 years down the road, or it could be even 7 to 10 years down the road. They'll develop AML as a result of the toxic exposure to chemotherapy earlier in life. It's rare, it happens less than 1% of the time with the common chemotherapy regimens that we use, but every time it happens, it's obviously a devastating outcome. But usually we give chemotherapy in those settings, earlier settings, when we really don't have much of a choice, when it's really considered to be necessary to cure their initial cancer. But I would say those are the two most common settings. Either they've had MDS or or breast cancer. Occasionally there'll be somebody that maybe just had a lot of toxic exposure earlier in life, worked around different alcoholic compounds or things like that, but that's a little bit more rare lately, because there's a lot more control over those things. Does that answer the question?
That was a great answer. Thank you.
Okay, I still don't have anything in the chat, so we're going to go ahead and pass it on to Dr. Blau.
Okay, thank you. Dr. Nimbury gave a great summary of kind of the background unifying theme of what brings all of us together, and why are we, why do you have three different people talking about three different, or actually more than that, many different types of disease. And as Dr. Nimbury has described, all of the different cells in our blood, if you took a drop of blood from your finger, put it under the microscope and stained it with a special stain, you'd be able to see all these different kinds of cells, many different kinds of cells. Red cells would be, red, they carry oxygen. White blood cells are different types, they fight infections. Platelets, they look almost like schmutz, and they help stop you from bleeding. But the really fascinating thing, reason I'm a hematologist, the thing that I've always found so fascinating is that all of these different types of cells in your blood, as Dr. Nimbury said, come from a common mother cell called a hematopoietic stem cell. And it's not really known how many of these hematopoietic stem cells we have in our bodies, but maybe it's roughly, people have estimated maybe it's somewhere in the range of 3,000 to 10,000 of these hematopoietic stem cells. But this very tiny population of cells that look they're not very impressive to look at. You can't look at it and say, oh, that's a hematopoietic stem cell. They look like a lot of other cells. But that tiny population of cells generates trillions and trillions of cells in the blood every day. And that happens throughout your entire lifetime. So it's kind of this whole fascinating process that links all of the different kinds of blood diseases, blood malignancies that we're talking about. So the one that I'm talking about is a malignancy of a type of cell called a plasma cell that's shown here, where, as a stem cell differentiates down to many different cell types, one of those end cells is a plasma cell, and plasma cells are kind of protein production factories. They make tons of protein, and they make tons of a specific protein called an antibody. And so, everyone here will be familiar with the term of what is an antibody. Antibodies help our bodies fight infections. And typically we make millions of different antibodies to fight a multitude of possible infections. And the antibody fighting cell is called a plasma cell. I don't know if you can see my cursor. I guess you can see my cursor probably, but you can see plasma cells are making all these antibodies. And when a plasma cell acquires damage to its DNA and a bunch of mutations, that can lead a nice plasma cell to go the wrong way, to go on the wrong side of the tracks and become a malignant plasma cell that can create this disease called multiple myeloma.
Oh, I think, Tony, I think you have to share your screen. I don't know if you wanted to share.
Oh my gosh.
Yeah.
I'm showing such
Dr.
cool
Nimbury.
stuff, such cool stuff. And you guys are missing it. Yeah, see, I was so cocky. I thought, oh, I know how to, I've done this a million times. I know how to share my screen. Let me see. Okay, here we go. Okay, there, you can see that. Is that working?
Just put it into the slideshow. That way you can see it.
You bet, you bet. Yeah. So, yeah, so I was just showing here. So can you see my cursor moving around a little bit?
Yes.
Yeah, so these are the nice plasma cell. These are pictures of the nice plasma cells that are making these antibodies that are protecting us from all sorts of infections. But then when they win, for reasons that are not well understood, a normal plasma cell acquires DNA damage and a particular set of mutations in a particular sequence. They can become bad plasma cells that are malignant now. And they also make a lot of proteins still, but instead of making millions of different antibodies to fight millions, all these different kinds of infections that we could encounter, now you have a plasma cell that just makes one antibody that usually doesn't do you any good. It's useless, except that it still can be found in the bloodstream, and it can be measured in the bloodstream, and it serves as a way of monitoring your myeloma. So you can see what's going on with a person's myeloma, not just by looking for the bad cells themselves, but you can look for them based on the presence in the bloodstream of this single antibody that's called a monoclonal antibody or an M protein. So it's kind of a convenient thing. It doesn't usually cause problems, that M protein. It can sometimes, uncommonly, but it serves as a marker for how much myeloma that you have in your body. Myeloma is usually, or probably almost always, preceded by what are called precursor conditions. So you don't go from normal person to myeloma kind of overnight. You develop kind of this slow accumulation of these nasty myeloma cells that grow kind of in a slow way oftentimes. And so you can have this condition that goes by the acronym MGUS, stands for monoclonal gammopathy of undetermined significance. Most people know, know this as MGUS, and this turns out to be a pretty common disease. As you get older, you find that more and more people have this MGUS, and what that indicates is that they have some of these cells that look like they're headed toward becoming myeloma cells. So it looks like some of those plasma cells are starting to overgrow and make some of this M protein, but but in the vast majority of cases, they never actually really develop into multiple myeloma. And so MGUS is not a cancerous condition. It's the kind of thing where when you get old enough, it's actually pretty common to have an M protein, a monoclonal protein in your blood. But if you follow those people over time, the vast majority of those people will never go on to develop a progression of that into multiple myeloma. And it's estimated that if you have MGUS, there's only about a 1% chance per year that your disease will progress to multiple myeloma. Now, there's an intermediate thing between MGUS and full-blown multiple myeloma. That's a condition called smoldering myeloma, where those few kind of nasty looking plasma cells. Looks like they might be on their way to heading to myeloma. They can grow to larger numbers. And if you pass a certain threshold of these cells in your bone marrow, then you get, you get diagnosed as having smoldering myeloma. Smoldering myeloma has a higher risk of progressing to multiple myeloma. About 10% of those patients per year progress to multiple myeloma. And if you have, and there are ways of classifying people with this kind of smoldering myeloma into those patients with high risk disease. And if you have a high risk smoldering myeloma, there's a lot of reason to think that maybe it would be good to start treating those patients to catch it early, if you will. And there are clinical trials that are testing whether that approach works. But then if you get, regular old, so-called full-blown myeloma, there are generally a few clues that, yeah, you can't just watch this anymore. It really is causing problems. And there's an acronym that's used to identify problems that will require treatment, that you have these now myeloma cells that have grown to such an extent and are causing such problems that, you better jump on this, you better do something about this. And so there are these criteria that are called the CRAB criteria, where the C stands for high calcium levels in the blood, R is for renal or kidney damage, A is for anemia, your red blood cell counts go down, and B is for bone lesions or bone fractures. And so not everyone has all of these things, but most patients at the time when they're diagnosed with multiple myeloma have at least one of these things. So this is kind of my background, and it's already been described. I've been at the University of Washington my whole life, but in 2013, I worked very closely with Dr. Senecal in the South Sound Care Foundation and my wife, Sibel, to create a new kind of clinical trial for patients with a miserable, incurable disease called metastatic triple negative breast cancer, where the disease progresses very quickly. And we tried to find a way of bringing the very best effort that the world could bring to trying to help these patients. And this was the second patient on our clinical trial, a lovely person named Kathleen Olivas. And this, and what we did in Kathleen was kind of emblematic of the trial and what we try to do still today. And that is finding a patient with an incurable cancer and bringing the world's best effort to try to help figure out what's going on. So in Kathleen's case, we got samples of her tumor metastases. We sampled her tumor cells from several different sites of her body. We subjected each bit of tumor sample to this very extensive analysis where we sequenced all the genes, all the RNA, lots of stuff, collecting billions of data points. And then we put that information in the cloud, made it accessible to experts from around the world who looked at it, tried to help us understand it to the best of our ability. And then we wrote a report that went back to the doctor and the patient. And then if the doctor and the patient wanted to try a treatment that could be helpful, we worked super hard. And we continue to do this now to find a treatment, to get the treatment for that patient. And then we'll find out, is it working or not? And use that patient's experience to help guide us into whether we're on the right track or not. So this is just a picture showing that in Kathleen's case, we brought 32 different researchers from 20 different institutions around the world to try to help understand what was happening in her. And that's a trial that now has enrolled, since it launched in 2013, I think it's enrolled over 50 patients. And this is a trial that could not have been done without the support of South Sound Care. So while we're kind of, hot into doing that trial, then I, as has already been mentioned, I myself got multiple myeloma. And this is the only picture of me that's ever shown up in the New York Times, where my tush is in the New York Times, where my doctor, Pam Becker, is sticking a needle back there. And it turns out that I had now the opportunity to be, have the perspective of a patient. Now, multiple myeloma used to be this really miserable disease. 20, 30 years ago, when I first came to Seattle to work at the Fred Hutchinson Cancer Research Institute, patients with myeloma seemed to do just terribly. But fortunately, very, very fortunately for me and myeloma patients today, there are many new treatments that have been developed for patients with multiple myeloma, some of which are shown here. And it's kind of this hotbed of discovery where the advances are really super impressive. And along with those improved treatments, this is just showing how long do you live. So this is how many years do patients with multiple myeloma live after they've been diagnosed. And you can see, in the 60s, people died super fast. And then with each successive, 5-year interval, the survival curves and the longevity of patients diagnosed with multiple myeloma has improved a lot. But there are still big challenges for people with myeloma and all cancers, really. These are challenges that aren't just for myeloma, they're challenges for every cancer patient. And the first challenge has to do with this concept of heterogeneity. And heterogeneity means differences. And the key difference that I think most people understand is that I have myeloma. I know many other people that have myeloma, but a treatment that works great for my friend with myeloma might not work for me. It doesn't mean that it's going to work for me. It's because the biology of our myeloma can be very different. Another kind of heterogeneity is that different doctors treat patients differently based on their experience. And so you could, so patients often seek second opinions or third opinions. And, the joke is that if you go to seek a second opinion, you'll often get a second opinion, or a third opinion, you'll get a third opinion. And so a patient's treatment is governed not only by the biology of their disease, but by who happens to be their doctor. And a large part of that is not because, there are bad doctors. A large part of that is because nobody really knows what the right treatment is for a particular patient at a particular point in time. And that's kind of the thing that struck me now from my newly won patient's perspective. This can be a little bit hard to see, but one good, it's a good problem to have a lot of treatment options. But if you have a lot of drugs to choose from, and they can be used in various combinations and in various sequences over the course of a person's disease, then you kind of wonder, okay, which drug should I be using, which treatments at a particular point in time? And so this shows my own treatment pathway. It's a very simplified cartoon of some of the treatment decisions that I've made. But in trying to make these decisions, I've been just flying by the seat of my pants. And what I've most wanted to know is, what did every other myeloma patient choose to do? And what happened to them? What were their outcomes? And let me use that information to try to understand what I should do in my case. But that information didn't exist. And so I ended up, over a period of a few years, I ended up retiring from the University of Washington and starting a company called All for Cure. And what All for Cure does is we've created this global network that aims to revolutionize the way that cancer is treated by creating an online platform for patients. And we have, over 1,100 patients, clinicians, oncologists, and nurses, and researchers, and bringing them all together into a common online platform. And patients register for All for Cure through a pretty simple 2-minute process. And then we ask them to sign HIPAA release forms to allow us to access all of the medical records from all of the institutions from which they've received care. And then I'll just dive off here for just a moment, just to show you what this looks like online, because it's a little cooler online than if I just show you a slide. But from the medical records, we create, we get all the medical records. We have a team that's specialized in multiple myeloma that extracts the information to create what we call a dashboard. And we've created dashboards now for 639 patients. If you register for All for Cure, you can go to this user tab and see all of these patients. And then you can click on any one of these numbers and you can see, a detailed history of what's happened to this patient. So in this patient, you can see we'll just reload this for a second. I've got like 1 trillion tabs open, I think makes it slow. But you can see all of the treatments that the patients received, and all of the labs that indicate how well those treatments have worked. So in this patient, you can, we take away the name, give it the patient a number, but this is the dashboard of a woman in her 30s who developed a really terribly aggressive myeloma soon after delivering twins. And this just shows all of the drugs that she received. These are drugs that are used for multiple myeloma. And this is that M protein that's secreted by the tumor cells. So you can see with all these drugs, and then here she got this procedure called a stem cell transplant, where, as Dr. Nimbury says, you take out some of the patient's stem cells, you store them in deep freeze, then you give the patient a big slug of a drug called melphalan, and then you rescue them by giving back. This melphalan is kind of an interesting concept. You give this dose of this drug, which I've gotten, it's kind of a nasty drug. You don't feel good for a week or two after you get this drug, sometimes longer, often longer. But melphalan, you give it at a dose that is sufficient to wipe out the person's bone marrow. And so if you just gave the melphalan at that dose, you would kind of be condemning that person to death, because their bone marrow is going to be wiped out and they're not going to be able to make blood cells. Will die of an infection. But the way you work around that is, before I've given you the melphalan, I've taken out your stem cells, I've stored them in deep freeze. And now after I give you the melphalan and after it's washed out from your body, I give you back these stem cells, and I just do it by giving you a blood, and I infuse them into the blood like a blood transfusion. And the stem cells are smart enough, not really smart enough, but they have molecules on their surface that cause them to what's called find their home in the bone marrow and now reestablish blood production. And so it's a little bit of a misnomer, because you're not really transplanting the cells from one person to the next like you do in an allogeneic stem cell transplant. Here, you're just parking some of your stem cells for safekeeping while you're giving this melphalan in the hope of really knocking down the myeloma to super low levels. So here in this patient, her myeloma was under control for a while, but what you can see is it started to come back and got to be, out of control. And very sadly, she died about 2 years ago. This is showing the summary of what happened to her in a lot of detail. So this is super helpful if you want to show your doctor, hey, this is what, if you're going to see a new doctor, this is what I've been through. Doctors can communicate through this platform pretty readily. And then these are posts. So now this is visible to a community of over 1,700 patients, clinicians, and researchers. And so these are posts by a member of our team pointing to some clinical trials that the patient might want to consider. These are posts by me. There's a post here by the patient correcting some of the information that we had. And then this is a post by Ken Anderson, who's probably the best known myeloma expert from Harvard, pointing to treatments that she might want to consider. And sadly, that wasn't enough. That wasn't enough to save her life. But then from these individual deep data sets for patients, we've created what we call a tool that summarizes all of the treatments that have happened across all of our patients. And now you can see, okay, for 642 patients, we've looked at over 2,000 treatments. And now you can see, okay, what treatment did the patient get? How long did they get it? And what was the outcome? And so you can begin to kind of learn, what happened to everyone else. And so just going back then to the rest of this, I just say a couple of more things about ways in which we've been able to help people. I think we have people that have benefited. We help lots of patients within All for Cure. This is a marathon running Alaska Airlines flight attendant who had a terrible myeloma, ended up in hospice, but through suggestions that came through All for Cure, she's able to leave hospice and go on to receive 2 stem cell transplants. This is a patient who learned through her participation in All for Cure that her treatment was different from most other patients, and she was actually not getting optimum treatment. So she changed doctors and ended up on better treatment. And this is a person who was getting a treatment that his insurance company didn't want to pay for until we were able to show the insurance company that not only did this treatment that he was getting work for him, it was also working for another patient. And so the insurance company agreed to pay for his treatment. We have a bunch of doctors that are increasingly, using All for Cure. And we have on All for Cure this, if you're interested in learning about myeloma, we have this thing called Myeloma GPS that has a bunch of videos. We have to find a better way to kind of show pictures of younger, better looking people rather than me. But this is just, you can see a video here about my approach to having myeloma is to squish it and keep it squished. So multiple myeloma is not a curable disease. You can't get rid of it's incredibly rare to have a patient that gets rid of every last myeloma cell. So my personal approach has been to try to bring my myeloma to undetectable levels and then keep it there. So it's not like that approach is completely without risk, but that's what I've chosen to do. And that's in part because of experiences as happened here with my dear friend Bard Richmond, who was the second participant on All for Cure, just a lovely, lovely person and an important advisor to me. But this is what happened to Bard on his, All for Cure dashboard. He got treated, his myeloma went away, he got a stem cell transplant here, but then it starts to come back, change treatment, and then it comes back again, and it comes back meaner, harder, faster, and until he died now about 3 years ago. So my approach has been to try to keep it just at this low, undetectable level and do everything that I can to maintain that state. So I think that's all that I have to say. And I've probably eaten into some of Dr. Senecal's time. So, and I do not want to do that. So, but I'm happy to answer a few questions.
I don't have any questions in the chat. I did have a comment just wanting some of your slides, Dr. Blau, blown up. So if you can send that to me at the end, I will email them to everybody.
You bet.
Okay, still haven't gotten any questions, so I'm gonna go ahead and hand it over to Dr. Senecal.
Okay, I hope you all can hear me.
Yeah.
Tony, that was great. I always learn something.
Oh, well.
So thank you.
Thank you.
I'm going to share the screen, I guess, I hope. So my job in the next 15 or 20 minutes is to go over two diseases. One is called chronic lymphocytic leukemia, and the other is chronic myelogenous leukemia. And we'll talk about the diagnosis, the symptoms, that sort of thing.
Dr. Senecal, do you
Yes.
mind
Opening it up?
putting it into the slideshow view?
Yeah, got it.
Perfect. Yep. You can see it. Thank you.
So just as you heard in the other presentations, it's important to educate yourself, to kind of try to get to know the disease. And that's can be a little bit challenging because there's an awful lot of information out there, some of it that's really good and some of it that's probably not so good. Get support, hopefully have people that you can talk to about this. And then I think it's very important to stay positive. Both of these diseases are marathons. They are not sprints. So unlike what Swathi talked about with acute myelocytic leukemia, these are diseases that are patients usually experience over a long period of time. So chronic refers to just that it's a long process, that these cells are not rapidly growing like acute myelocytic leukemia. They're kind of slowly accumulating. In fact, that's one of the problems. These cells kind of don't know what to do. They don't die very effectively. They just kind of accumulate. And they're lymphocytic. So they're the same cell line as actually the plasma cells. They're lymphocytes, but they don't produce that immune globulin that Tony talked about. And they involve the bone marrow and involve the peripheral blood. These are some of the other types of leukemia that you'll hear about. Acute lymphoblastic leukemia, which we're not going to talk about today. That's a little less common in adults, more common in children. And then chronic myeloid leukemia I'll touch on, and Swathi talked about acute myelocytic leukemia. There's one additional comment that we can make is this about this issue of small lymphocytic lymphoma. In some cases, CLL, or chronic lymphocytic leukemia, really behaves more like a lymphoma. It forms, the lymphocytes form lumps in the lymph nodes. So they involve the lymph nodes, and the lymph nodes kind of grow in size. And it spares the blood. The blood may not have very many lymphocytes in it. It may have some, but this is kind of a subcategory. It's basically the same though as CLL and treated the same. So you can have the leukemia form of it, or you can have the lymphoma form of it. And this is just a slide to let you know that it's heterogeneous, really just like all of these diseases that we've discussed with you. Many patients with CLL have the lymphocytes only slowly accumulating and growing over a period of time. I have many patients that I've followed over the years, And a significant number of them I haven't had to treat for 2, 3, 4, 5 years because the disease never caused a problem. And I know that sounds a little bit crazy, but it never really was threatening the patient's health. So I did not treat it and we just followed it. In other cases, though, it can be more aggressive. It can evolve relatively quickly. And in that case, treatment's called for. The other thing that you have to remember here is that, as I said, you're in here for a marathon. This disease is not really curable. There may be exceptions to that that are perhaps due to investigational options like allogeneic transplant, which isn't commonly done for this disease, but there are a few patients who are cured with that. And then perhaps with CAR T cell therapy, there are some patients that can go into remission for several years. So other than those exceptions, though, it's not really a curable disease. These are some key points or key terms that your doctor will use when he's talking about or she's talking about chronic lymphocytic leukemia. So it's the most common leukemia in adults, 21,000 new cases. Average age is 71, so it occurs in folks that are a little bit older. I'm almost 71. I don't consider that older. Okay, many people who have CLL do not have symptoms, as I mentioned, and that's great. That's actually really important. I talk to all my patients about how they're feeling, and sometimes it's a little sneaky that they feel pretty well, but then in retrospect, they'll say, gosh, in the past year, I'm a lot more tired than I used to be. So you have to kind of think about, compare how the patient was several months or a year before to get an idea as to, are they more fatigued? Are they getting tired more easily? If the disease is behaving more aggressively, you may see some of these signs, such as weight loss, night sweats, feverishness. And then if the CLL cells accumulate to a greater extent in the bone marrow, can actually cause the blood cells, the other normal blood cells, to be depressed. And patients then develop anemia and a low platelet count. So this is just emphasizing that some patients don't have any symptoms, some patients do. Many times when they're first diagnosed, patients don't have any symptoms. Maybe the most common referral is that a patient with chronic lymphocytic leukemia is referred by their primary care doctor because their lymphocyte count was a little bit elevated when they had a CBC done. So they just had their annual exam, everything was fine, they had their CBC done, and the doctor sees that the lymphocyte count is elevated, which is catches his eye or her eye, and then refers us, the patient, the hematologist, takes a look at the situation. So that's the background of CLL. And now we're going to talk about chronic myeloid leukemia. So this is a different kind of leukemia, and it involves that same collection of cells that Swathi was talking about, the myeloid cells. And it's not necessarily the immature cells. It's actually a cross-section of the myeloid cells. It's the intermediate cells, as well as the mature myeloid cells that we see overproduced in CML. So it's a blood cancer that starts in the marrow. It's the first blood cancer that was characterized by a particular genetic alteration. 2 chromosomes, the 9th chromosome and the 22nd chromosome, have a break. There are specific spots where they can break, and they translocate, they switch, so that a piece of one chromosome goes to another chromosome, which of course should not happen. But when that happens in these blood cells, in these stem cells, the result can be or is chronic myeloid leukemia. So Dr. Hungerford in 1960 identified this as the sine qua non, or the diagnostic characteristic that makes the diagnosis of CML. So we still look for that translocation in the 9th chromosome and the 22nd chromosome in order to make the diagnosis. BCR-ABL is referring to the particular genes that are involved in that translocation. And those genes make so they shouldn't be together, but they're brought together by that translocation, and they produce a protein that drives white blood cell production, or myeloid production. So the white blood cell grows and grows and grows in the peripheral blood and in the bone marrow. In terms of symptoms, some patients don't have symptoms when they're diagnosed with CML. It might be the same thing as with CLL. The family doctor does a blood count and notices that the white blood cell count is elevated and doesn't like that, and then refers the patient to the hematologist. However, it can cause some symptoms, and ultimately, eventually, it will always cause symptoms. So unlike CLL, it always turns into a more aggressive disease. And these are some of the symptoms that patients may have. Diagnosing CML is not hard for a hematologist. It's one of those few diseases where you look at the blood under the microscope and you can get a definite feel for that being the diagnosis, CML. It's one of the reasons I went into hematology, is because you can just go to the microscope, look at the blood smear, go back to the patient in 10 minutes and say, you know what, I think this is CML, and let me tell you a little bit about it. However, the way we really make the diagnosis is by doing that molecular testing that I mentioned, looking for that translocation of the 922 chromosome and or the BCR-ABL transcript, which is a product of that translocation. Now, we hope that most patients that have CML are in the chronic phase, which means that they're in a relatively stable phase. Their bone marrow is making too many cells, but it's not too difficult to control. But as I said, it invariably evolves. And it evolves because additional genetic changes occur in those cells that drive further evolution of the disease to a more aggressive phase. And the first part of that is called acceleration. So that's acceleration of the disease. The cells are growing more quickly, more aggressively. The spleen probably will increase in size. And then it can evolve to this phase called blast crisis, which is a frightening disease, difficult to treat, very aggressive, and I'd rather nobody get that. But without treatment, CML will evolve to that point. So this is just a slide to make sure that if you're diagnosed with CLL or CML, either one, you want to have a good idea of what the test results were. Why is that diagnosis being made? Are there any particular markers, for example, that translocation or the BCR-ABL transcript that have been measured that tell the doctor for sure that's the diagnosis? You should have an explanation of your symptoms, and then how to control those symptoms. Then there, of course, should be some discussion about treatment. And with both these diseases, thank goodness, there are a lot of options for treatment that we can discuss. Treatment for CLL, somewhat like leukemia, somewhat like myeloma, has evolved quite a bit in the past several years. As I mentioned, some patients don't have any symptoms and don't feel bad at all, and their exam is pretty unremarkable, and their blood work just shows an elevated lymphocyte count. And in those patients, many times we'll just observe them. It's called watchful waiting. And so we just kind of observe. And that's not a bad thing to do. You might think, well, I want to start treatment quickly. Well, remember, we really don't consider this a curable disease. So we're all about wanting to make sure that the quality of life is good. And if a patient isn't threatened by the disease, why pursue treatment right away? It's just as reasonable to observe. So watch and wait is a reasonable option, but it requires that you really watch. You can't just pat the patient on the back and send them out the door. They have to be monitored. So if you have CLL or get CLL or somebody in your family has it, you want to, and you're on the watch and wait program, you want to know, well, what are you watching and waiting for? What are the signs and symptoms that I should be aware of? And how often should I be seen? And what are you looking for, doctor, that might drive you to consider treatment? These are a few of the things that might indicate a need for treatment to be considered. Lymph nodes that are enlarging, the spleen enlarging, a decrease in blood counts like anemia and thrombocytopenia. Those disturbing symptoms, like weight loss, fever, night sweats, that's not good. And so we would want to pursue that and consider treatment in those situations. So as I said, the treatments have really evolved significantly in the past several years. I'm going to kind of jump to that right now and kind of comment on that. It used to be that we would use chemotherapy, or use chemotherapy with a medicine that is referred to as immunotherapy called rituximab or Rituxan. That's used, this combination of drugs, chemotherapy and rituximab, is used less frequently now, although occasionally we do use it. It used to be we would use in that second line, you see a drug called chlorambucil or Leukeran, and that was a drug that I used back 35 years ago for treating CLL. It's not often used these days because we have better medicine. And the medicines that have really kind of revolutionized the treatment of CLL are the ones on the bottom of this page. Ibrutinib, acalabrutinib are two relatively recent drugs that have been developed that are generally quite effective in treating CLL. Not always, but in a high percentage of patients. And the beautiful thing about these drugs is that it's like taking your vitamin pill every day. And if you take your vitamin or you take your ibrutinib, you just take it the next day and the next day, and it's entirely possible that the disease will remit or quiet down. Now, I didn't say cure, but that the lymph nodes decrease in size, the sweats decrease, that the patient has more of a normal sense of their health, a more normal health. Now, the downside of these medicines are there can be some side effects, and I won't spend a lot of time on that, but there can be, so that they have to be monitored certainly closely, and sometimes because of the side effects, that you just can't use it. The side effects are too significant. But these drugs, ibrutinib, acalabrutinib, and there's a third one that was just released, are really very effective. Monoclonal antibodies like Rituxan can also be effective. And on this slide, several monoclonal antibodies are listed. Sometimes they're used in combination with ibrutinib or acalabrutinib, depending upon the patient's situation, their general health, that sort of thing. This is a slide that's commenting on stem cell transplant. I've only had one patient who's had a allogeneic stem cell transplant and survived. And she's cured of her disease, but it was pretty tough. It's pretty hard. And I think that that's because with CLL, people don't really reach for stem cell transplant unless the patient is, number one, quite young, number two, has disease that can't be treated any other way, because the risk of the transplant is very high. The risk of having a complication and even death is unfortunately quite high. Now, CML is also a disease where there have been some incredible improvements in the past 15 years. Really, let's see, Dr. Drucker, who is Tony Blau's friend, Brian, developed the first targeted therapy for this in like 19, I'm going to say like 90.
I was thinking, yeah, I was thinking 99 maybe, Frank, 98, is that right?
That probably is right.
I'm not sure, yeah.
I remember I was on an airplane with him when he was going to go present the information to ASH at our American Society of Hematology meetings. And I had known him from the past because I had referred him patients, and the guy was giddy. He was so excited. And what he developed is a drug called imatinib. And imatinib is listed down there among those 4 or 5 drugs there. It was the first drug to target that specific transcript that I mentioned, the BCR-ABL transcript, and stops it in its tracks, or can. It's very likely that it will. So it stops it. It stops the signaling that occurs in these malignant cells. So they die. They just die. And really a high proportion of patients will go into remission with that treatment. Now, since that time, we've learned that the disease can develop resistance to imatinib, and other medications have been developed that have the same strategy as imatinib, but overcome the mechanisms of resistance that have been that the CML cells develop. One of them is dasatinib, there's nilotinib, bosutinib, and ponatinib. And kind of weird names, I know, but at any rate, for certain specific indications, they can be very, very effective. And so the physician and the patient need to talk about what would be the best medicine for them. In some cases, it's plain old imatinib, which has been around for 30 years. But in other cases, it ought to be one of those others. So it requires a discussion. And you also have to get to know your medicine really well, like when to take it, what other medicines that might interact with it, what foods might interact with it. So you have to be careful with these medicines. Finally, if those medicines don't work, and that's really the minority of patients, stem cell transplant can be considered, but that is not common these days. CML used to be like one of the most common diseases that we transplanted at Fred Hutchinson Center when I was a fellow there 40 years ago. It's just not now. It's not common, and it's because we have these better medications. This is just to remind me to talk to you a little bit about this new drug on the bottom here, Cinrybo. This is a drug that we're learning how to use, but it looks like it's pretty cool and can be very effective even with patients who where those TKIs that we listed, like imatinib and such, are not working. And as I said, that's the minority. That's a small number of patients. But this drug seems to overcome that resistance, and it inhibits certain aspects of protein synthesis, we think, and looks like it was just released in the past 12 months, but it looks like it could be very helpful, particularly for those rare patients that are having trouble. I won't talk about immunotherapy because we don't use it very often anymore. Monitoring treatment is not hard to do in CML. We monitor the blood counts, and then we measure that using cytogenetics, and we measure that BCR-ABL marker in the blood or in the bone marrow. So it's very easy to see how well a patient does and counsel the patient as to whether the disease is responding the way we want. So we talked about clinical trials. Swathi did a nice job doing that, and Tony did. So I won't go over this again, but just to say there are clinical trials in all these diseases, and we should always be looking at clinical trials. I would say that for CML and for CLL, there are very good treatments that are the standards of care. I'm not sure that we need a clinical trial for the standard, which is so effective. But if the disease returns or proves difficult to treat, you want to make sure that you consider clinical trials. And then the issue of coping with side effects, important to, with these medicines that we treat CLL with and CML with, all these medicines have some side effects, some worse than others, but have to go over those side effects, how to manage them, and how to minimize them. And these are some of the side effects that can occur. Swathi talked about palliative care, always an important component of how can we help the patient feel better while they're on treatment? Or if they're off treatment, how can we make the patient minimize symptoms so that their quality of life is good? This is a list of things that, tools that sometimes we use in CLL. So additional points here, you want to maintain a healthy lifestyle. It makes it so much easier if I have a patient who really does take care of themselves. If they have diabetes, they control it. They don't smoke. If they're overweight, they try to get back to a more healthy weight, that they exercise, that they eat a really good diet, lots of vegetables, that they minimize alcohol intake. It's so much easier to care for a patient who really takes responsibility for those things. And it doesn't matter what the disease is, it's always true. So I'm going to go through this because we're kind of running out of time. Are there any questions?
Yes, Dr. Senecal, I did have a question come through the chat. It looks like the patient's about to start ibrutinib. And the question is, what is the increased percentage of effectiveness in the combination with ibrutinib?
So ibrutinib sometimes is used with Rituxan, but actually I use it by itself most often. And it's about, it's a little bit over 80% effective. It's not, as we talked about, it's not a cure. If we stop the medicine, the CLL does come back, but it's about 80% of the time, it'll take the disease into either a full remission or knock down the CLL to the point where clinically there aren't really any symptoms of the disease and the patient's quality of life is really good. So it's pretty high. So hopefully you won't have any side effects from it. The most common side effects are diarrhea, bruisability, easy bruising, and then there can be this heart arrhythmia problem, atrial fibrillation. But we can usually get by most of those problems without too much difficulty. So, yeah, I think it's a very reasonable choice.
Thank you. Another question is it more aggressive form of CLL in a 53-year-old female?
Not necessarily. I don't think that age is necessarily considered, a good or bad factor. Of course, we'd rather you didn't have it at that age. But there are prognostic factors for CLL that are pretty well identified, and they're molecular changes that are the prognostic factors. And that is something that you can discuss with your doctor about kind of what were the molecular changes in my disease? Does that reflect on what kind of treatment I ought to get? And sometimes it will. In other words, some medicines are better for certain molecular changes and not for others.
Thank you. One last question is with ibrutinib, what is the increased effectiveness of monoclonal antibodies?
Yeah, it does improve the odds that the ibrutinib will be effective by about, I'm not sure I know the absolute number, but probably on the order of 10% or so, maybe a little bit more than that. But the problem is that the monoclonal antibodies suppress your normal B cells as well, and they're already suppressed from the CLL. So you're not going to be producing infection-fighting immune globulins as well. It will suppress your immune system. So if I have say a younger person with CLL where I want to be very aggressive, I might do that combination. I might use it. If I have somebody who's a little bit older where I'm worried that if they got an infection, it might be very difficult for them to overcome it, I might not use it. Usually I do not use it, but in the right patient, it certainly is a consideration.
Okay, thank you. I don't see any other questions in the chat. So I'm going to go ahead and I'm going to stop the recording. And that way, if anybody wants to unmute yourself and turn your camera on, you can go ahead and do that. We are going to be having a raffle, so please stay on. Thank you.